Hello, hello. Welcome to this week's episode of Ask Dr. Jessica. I'm here with Dr. Nina Shapiro, ENT extraordinaire. Hi, Dr. Shapiro.
Hi, Dr. Jessica. Great to see you.
Great to see you too. I'm so excited to have you here. We'll talk about all of the questions that I receive most commonly about when to see an ear, nose, and throat doctor. So what is an ENT exactly? What is an otolaryngologist? What kind of training does it take to get to where you are?
So, an ENT or otolaryngologist is, we are all trained in surgery. And typically, the way it goes is after 4 years of medical school, we apply to ENT residency. And most ENT residencies nowadays are 1 year or actually 6 months for a lot of them, 6 months to 12 months of general surgery. And then 4 to 4.5 years of ear, nose, and throat residency. And during residency, we do all the areas of ear, nose, and throat. So we do laryngology, which is just voice disorders. We do head and neck cancer. We do ear surgery. We do sinus surgery, pediatric ENT, general ENT. So we do a little bit of everything in those 4 to 4.5 years. And then I'd say about 2/3 go on to do another year or two of additional training. So I went on to do pediatric ear, nose, and throat fellowship after ear, nose, and throat residency. So that was for me a year. And in that year, you do just your area, so just pediatric ENT. Even within that, there's some pediatric ENTs who do just airway surgery or just pediatric ear surgery or pediatric sinus surgery. So it gets really, really, really sub specialized. But most of us in pediatric ENT do a little of everything. So it's ENT just for children.
So out of curiosity, what are the most common procedures that you do as an ENT?
So most common, and these are in the healthy kids, ear tubes is the most common procedure we do, and it is the most common procedure that is done in the United States on children. About 1 million ear tubes are done per year in this country.
Wow.
The next common is tonsillectomy. About 300,000 to 500,000 tonsillectomies are done per year in this country. So that's the second most common procedure.
And do you notice that there are fewer and fewer of these procedures done as time goes on?
Well, certainly during pandemic, we saw, and I'm sure you in pediatrics also saw very, very few kids with ear infections, ear problems, things like that. So we did very few tubes in the past year and a half. It is back though, so we're seeing lots of kids who've had recurrent ear infections, 3, 4, 5 infections in the last few months. So ear tubes are back. I would say they're pretty steady as far as how frequently they're done over the past few years. Tonsillectomy kind of goes up and down. So back in the 70s and 80s, or actually 60s and 70s, everyone was getting their tonsils out if they had one or two sore throats. Then it was sort of recognized that that was not necessary. Not every child needs to get their tonsils out, and so nobody was getting their tonsils out. And then sort of in the 1990s, we were starting to see kids with sleep apnea, which we would think of most typically for adults. And so we realized that the sleep apnea that young kids were having, even as young as 2 and 3 year olds, was because of big tonsils and adenoids. So then tonsillectomy and adenoidectomy sort of saw an uptick back in the 90s, and it's still pretty much where it is, where it was then. So not like it was in the 1960s and 70s where everyone got their tonsils out, the whole family got their tonsils out, but it's still pretty common, mostly for sleep disorders, so snoring, sleep apnea, things like that.
What are some guidelines for parents if their children do get strep throat? After how many strep throat infections do you like to see them? Is there a number in your mind when they should, when it would warrant seeing an ear, nose, and throat doctor?
Yeah, so there are published guidelines as far as what would be an indication for considering tonsillectomy if it's purely for infection. So for that, we say 10 episodes of strep throat in 1 year, which is a lot. That's almost once a month. Or 5 episodes, greater than 5 episodes per year for 2 years, or 3 episodes per year for 3 years. So that's sort of the standard guidelines for just strep throat with no other symptoms, meaning no snoring, no sleep apnea, no other congestion, just recurrent sore throats. But that's a really small percentage of the patients that we see who need their tonsils out. I would say 90+% of the children that we see as pediatric ear, nose, and throat doctors who need their tonsils out, it's for breathing issues. So snoring, noisy breathing, mouth breathing, sleep apnea, struggling to sleep, poor sleep quality. That's what we see mostly as far as kids who need their tonsils out. It's my clock.
That's really interesting. A couple things you said I want to touch on. One is this idea of 10 infections per year. That sounds so high. So you mean to tell me if somebody has strep throat infections over a year and they come to see you, your recommendation would be not to get their tonsils out?
Well, I mean, 6 to 7, we would, certainly consider it. We also take other. It's not just sort of like checking the boxes. So,
Right.
was it really a tonsillitis or was it just a sore throat? And if so, why did they have a sore throat? Do they have allergies? Do they have other, another virus going around? Is it just normal? Kids. Certainly preschool kids get 10 colds a year. Was it just 10 colds that they had? So there's certainly some wiggle room in all of that. If it was 7 really bad episodes of tonsillitis in a year, and the child is miserable and has missed 30 days of school, that would certainly be an indication. So it's not strict guidelines, but that just sort of gives us a framework, and then to see what else is going on.
Now, as far as snoring, so this is a common question that comes up. Kids are very loud nasal breathers. I would say I hear this from parents often, even at the 1-month visit. At what point should snorers come and see an ear, nose, and throat doctor?
So snoring is one of the most common things that we see. And what I say is that a little bit of snoring in everybody is normal. It just means that there's some turbulent airflow. But what I tell parents to look at is, what is the child's breathing pattern? Is it in and out regular breathing, or does it sound sort of off, irregular? Do they have any gasping or coughing or pauses in their breathing? Do they seem to be struggling? Do they look like they're uncomfortable, arching? If it's just a little noise, certainly, when they have a cold, I would consider that normal. But if it's snoring to the point where they seem to be having disrupted sleep, and certainly any sort of sequelae of that. So kids who have, even if they're getting 10 or 11 hours of sleep, but they're snoring and have this irregular breathing, they'll probably be sleep deprived, right? Relatively sleep deprived, and seem sort of irritable and either fatigued or, sort of tired and wired. So I put all of that together to see if it's really an issue that we need to address.
I have to say, when children do get their tonsils and adenoids out, almost always the parents are happy when it's over. They notice a marked improvement in their children's quality of sleep and honestly in their behavior. So it must be a really rewarding surgery to perform.
It is, even though you think it's kind of gross. It's really satisfying because it's just opening up their airway. And there's so many other things that we're learning. It affects their speech. So kids who have kind of garbled, we call it golf ball speech or hot potato speech, where they sound like they have stuff back there, and it affects their articulation and their ability to communicate. So that improves. Oftentimes if kids have poor eating and they have trouble swallowing, or they have sort of muted sense of taste and smell, a lot of the, not just picky eaters, but kids with real, struggling to eat, it improves that, improves their school performance, their athletic performance, when it's really necessary, and, it is life-changing for these kids and for the families as well, obviously.
One thing I remember when I spent time with you in residency, I remember listening to you talk to parents, and you explained adenoidectomies, or removing the adenoid. Mm-hmm. And just for parents listening, if they're on the fence about having the procedure done, one fact that you pointed out was that the adenoids, when they're removed, you said it's a tonsil right behind the nose, I remember. And you said, right, you described it as a tonsil right behind the nose. and that when it's removed, it's not as painful because the recovery time is pretty short, correct?
Yes, yes. So if most kids who have tonsil surgery for snoring, it's actually tonsils and adenoids. And then often parents will say, "What, the adenoids too?" And I remind them that, or I explain to them that taking the adenoids out won't really add any recovery time. If they're having their tonsils out and their adenoids out, 99% of their recovery is going to be from the tonsils. If a child has snoring and nasal blockage, and they have tiny tonsils but huge adenoids, and all they need is their adenoids out, it's a very easy recovery because it's up behind the palate. So they are not. It doesn't hurt when they swallow. Most kids can go to school like 2 days later. It's a little sore, scratchy throat, so it's magnitudes easier than a tonsillectomy recovery for sure. It's a rough week or two usually for the recovery, for tonsils, that is. But once and the younger kids, they bounce back much more quickly than say teenagers or adults, as with most things. So if you can get just sort of expect that it's going to be a rough week or two, and then beyond that, it's great.
Right. I think all of us can remember that friend that had their tonsils out that got ice cream for the week.
Yep, still goes.
Still. And then is there an age that you'd like to see kids that are snoring? Because I've also learned that when kids snore at 3 or 4, it might improve by the time they're 5 years old when they're, when the size of their pharynx or their oropharynx
Yeah.
catches up with the size of
Yeah.
their tonsils. Do you recommend waiting when children snore until they reach the age of 5 or 6, or do you think it's better to see you sooner than that?
And anytime if it's significant enough that it's impacting the sleep quality. I see kids under 2 who have huge tonsils and huge adenoids. It's less common. Obviously, most of the kids are sort of the 3 to 8 year olds who get their tonsils out for snoring. But I certainly see younger kids, if they're having sleep apnea, who need their tonsils and adenoids out. So we wouldn't necessarily wait if they're really struggling. If it's just snoring in a toddler, it's certainly something we can monitor. Sometimes we'll get a sleep study, an overnight test that measures their breathing quality if we're concerned. But it's good to take care of this if it's anything more significant. I would say before kindergarten.
I think that's
Yeah.
wonderful advice. I'm thinking right now of a 2-year-old I saw in our practice a couple of weeks ago who recently had his tonsils and adenoids removed, and the mom is so happy. She said
Yeah.
he's a
Yeah.
happier kid. He's sleeping
Hmm.
better.
Yeah. Yeah.
So it's
Yeah, and they
wonderful.
and they recover pretty quickly. Again, even the 2 year olds, have usually a pretty quick recovery. Their tissues are healthy, and they're meant to heal. So it's
Now,
nice.
what about a lot of parents will notice tonsil stones
Hmm.
on their children's tonsils? Is that a problem? Is that a reason to see an ear, nose, and throat doctor?
Tonsil stones, which are really like these little pellets, these little white spots. It's not really an infection, and a lot of that I see that more commonly in teenagers, based on the shape of their tonsils. So if they have these little pockets, what we call crypts, almost looks like little Swiss cheese holes in the tonsils. And what those little stones are, it's a combination of food debris, saliva, and a little bacteria all mixed together. A lot of people like to pick out their tonsil stones. It's kind of like picking your pimples. Don't do it. It creates a little inflammation in that little crypt, and then a new tonsil stone will form more quickly. Oral rinses, like warm salt water rinses, are good. Some people like to use like water picks to loosen them, but that also tends to irritate it. If they're really bothersome, and some people will say, listen, I spit out a tonsil stone the size of like an orzo pasta, or a large piece of rice, and that's happening all the time. Sometimes they cause really, really foul breath, which can be very bothersome, especially to teenagers. We can talk about tonsillectomy. I think at that point they need to understand what they're in for. Certainly for a teenager to have their tonsils out, that it's going to be a rough 2 or 3 weeks. But if they're really motivated, and those stones are really, really disruptive, we can certainly consider doing that.
That's good to know. So if you can leave them alone, leave them alone.
Leave them alone. Yeah, try some oral saline rinses. Kind of leaches them out a little bit. If you do that on a regular basis, sometimes they go away. But if it's really so disruptive to your life, we can consider taking them out.
Just to bring us back to ear tubes, if that's okay. Um, ear infections are something that come up so frequently as a pediatrician. I'd say most of the kids that I see have an ear infection by the time they're 2 years old. Um, Given that they're so common, when, when should a kid see you because of frequency of ear infections? Is there a certain number as well of ear infections where you think they should be seeing an ear, nose, and throat doctor?
So, I think it depends. Yes, ear infections are probably the most common thing that a pediatrician sees as far as any sort of illness that walks through the door, because they are respiratory infections. So it's just an extension of a cold or a cough. And then, when you take a look, you see that their ear's infected, and maybe the family wasn't even bringing in the child for that. Oftentimes, I'll find out that they went to the pediatrician for one thing and they found an ear infection. So they are so common. Reasons that I would need to see a child for ear infections are a couple. So one is the number of ear infections. So if they've had, say, 4, 6 infections, even if the infections get better, but if they seem to be frequent, so 4 to 6 infections in, say, a 6-month period, that's a good reason for me to take a look. The other is, these complicated ear infections. So oftentimes families will come in, they'll get antibiotics for an ear infection. The ear infection won't get better. Then they'll get another course of antibiotics. Then they'll get antibiotic shots. And then their eardrum will rupture, and one thing after the other. So if it's a complicated, even if it's just 1 or 2 like that, that's a reason for me to take a look. And then also are the kids who, even if they don't have infections, but they have fluid behind their ears, and the fluid sort of gelatinizes and becomes really thick, and it starts impacting their hearing and their speech development, and they develop some hearing loss. Certainly if that's there for more than a 2 to 3 month period, that's time for me to take a look also.
Yeah, I often tell parents as soon as we feel like they're on antibiotics more than they're not, if we're going on a couple of months and it seems like they're just continuously
Yep.
on antibiotics,
Yeah.
I like them to see an ENT.
Yeah, I agree.
Now, just to clear this up, because this is a medical myth I hear often from parents, can a sibling pass on another ear infection to another sibling? In other words, are ear infections contagious?
Respiratory infections are contagious. So you can get a cold from a sibling, but the ear infection is internal. It's behind the eardrum. So they are not contagious in that way. But, if a child is sneezing and coughing and happens to also have an ear infection, they can transmit that sneezing and coughing to their sibling. But that doesn't necessarily mean that their sibling will also get an ear infection. And the other myth that I often hear is that patients will say, my child had a double ear infection. Like that's some sort of rare medical finding. Most ear infections, and double means both sides, most ear infections are in both ears. So don't be surprised if your doctor is not sort of floored by that term. It's pretty typical.
It's pretty typical as far as ear
Yes.
infections go.
Yes.
Another question to ask you, does every ear infection require antibiotics? In other words,
No.
in Europe, it's very popular to do the 48-hour watch and wait, where we'll treat the pain and then evaluate a couple of days later and see if the ear infection resolves. What do you think about that?
I agree. I mean, I think if it's a young child, young meaning under 6 months old, or even under 2 in some circumstances, then they are, the really young babies are at higher risk of complications from ear infections. Other than that, an older child, preschool or elementary school, it is very reasonable to wait and treat the pain with either Tylenol or Motrin for 24 to 48 hours. And if symptoms are better, then we're good. And, we are in an antibiotic crisis here in this world from overuse of antibiotics and developing all these resistant organisms, which is why so many infections don't respond to the basic amoxicillin or even augmentin. That I think it is very reasonable, just like colds are from viruses, so are ear infections. Give it a day or two, and if your child is feeling better, it's reasonable to hold off on antibiotics. Definitely.
I'm glad you said that, because sometimes parents assume that ear infections will always warrant an antibiotic, but there are cases where it's reasonable to treat the
Many
pain
cases.
and wait. Yes.
Yeah. Yeah. And
Um,
it's tough because you bring your child, you take off from work, you bring your child, you take them out of school, you bring them to the doctor and they have an ear infection, and then you leave the doctor's office with nothing, or you feel like you're leaving with nothing, and you
right.
want that little piece of paper with the antibiotic. But I think if we really emphasize how, it's probably a virus, and what I often do, and I'm probably a lot of pediatricians do as well, just for simplicity, is we'll say, well, I'm going to order this antibiotic, but please do not take it unless your child is not better in the next day or so. Then you can go get it filled. I think that's
Right.
probably a very reasonable thing to do.
I like that trick. You can empower the family. You have the
Yeah.
prescription just in case you need it, but
Right. Don't
you
take
might
it.
save your child the medication.
Yeah. Yeah.
Why is it that little kids, tend to have more ear infections than older kids? Is there a reason why that's so?
Several reasons. So one is young children, so toddlers primarily, are not the most hygienic of creatures, and so they tend to get more respiratory infections, which lead to ear infections. So preschools, especially, where there's a lot of physical touch and contact, they just tend to breed a lot more goo in their nose, so to speak, and that goes to their ears. And then the other is their physical immaturity. So their eustachian tube, which is sort of the pressure regulating tube between the middle ear where fluid builds up and the back of the nose, is short and straight in little kids, and then as they get older it gets longer and angled down, and they're able to clear more, which is why adults don't tend to get ear infections as often as children in general. So part of it is their structure. Their immune systems are slightly less mature when they're, say, 12 months or 18 months. So they just tend to get more respiratory infections, and which lead to ear infections.
But from what I read, the number of ear infections and therefore ear tubes have gone down because of the vaccines, the Hib vaccine and the Prevnar vaccine in
Yeah.
particular,
Yeah.
because those prevent against the main causes of bacterial ear infections, which I think is a great benefit.
It is. I mean, most people don't think about those vaccines as ear infection vaccines, but definitely, certainly Hib, which is a very, very potentially dangerous infection. And I saw some of that during residency because Hib was relatively new then, which is the Haemophilus influenza B vaccine for. Very, very complicated, life-threatening ear infections, meningitis, leading to, profound hearing loss. So we rarely see that. And then Prevnar, which is given, I think it's a several dose vaccine, if I'm not
Four.
mistaken, 4-dose vaccine. That is the pneumococcal vaccine, is that correct? And so that's
Correct.
preventing a lot of the bacterial infections that we were seeing before that vaccine came about, which I believe was in the probably mid 1990s, late 1990s, not too long ago. That's a relatively new
Yeah,
one.
my husband wrote his medical school thesis on the Prevnar vaccine.
Oh, that's amazing.
And just so parents have a picture of what to expect, if they are told by an ENT that their child should get tubes placed, what is that procedure like? What's the recovery like? And does it change their life after the tubes are in?
So hopefully it will change their life for the better. We do try to do surgery to make people's lives better. So tubes are probably the quickest. To even call it a surgery, it's the quickest procedure that they can have done. It's extremely safe. We do it usually in an outpatient center if it's a healthy child, and they just breathe an anesthetic gas. They don't have an IV place. They don't get a breathing device. They're just going off to sleep, breathing a little laughing gas and another anesthetic. It takes about 5 minutes to do the procedure. And we, look under the microscope, make a little opening in the eardrum, drain out the fluid, and insert a little tube, which is about 1 millimeter. And then the child wakes up, has a little juice or popsicle, and then goes home about a half hour later. So it's a really, some kids could be home by 9 in the morning after surgery like that. I usually have kids use a couple days of eardrops, and most kids go to school or daycare or whatever their activity is the next day. There are virtually no restrictions after ear tubes. The young kids, and by young I mean under age 3 or 4, I don't usually recommend that they need earplugs for swimming or bathing or showering. They can fly in airplanes because their ears won't pop with the pressure change. So it is life changing. It really does make their lives more comfortable. A lot of these kids are miserable, getting infections all the time. A lot of kids have trouble sleeping because the ear pressure builds up while they're lying down. So all of that is relieved. A lot of the kids with speech delay or hearing loss, their language explodes, within the weeks after ear tubes because they can finally hear. So it's one of the greatest procedures. It's so quick. It's very delicate. We use these tiny little instruments under a microscope. But what's so great about it is virtually no recovery, and it is life changing for these kids. So it's one of my favorite
I'm
things to do.
I'm sold.
We'll all get ear
I'm
tubes.
definitely sold. I'm. It's nice, I think, to hear that. I like to hear that children don't have to be placed under general anesthesia to have the tubes
Well, it
placed.
is it is general anesthesia, but it's not to the point. So they are completely asleep. So it's more than just like laughing gas at the dentist, where they're just kind of a little bit loopy. They're completely asleep, but it's not. They don't need to be intubated, and they don't need an IV. But they need to be completely asleep because it's so you can't really touch an eardrum with a tiny little knife on even on a semi-awake child because if you don't want to slip, right?
Of course, but it's. I guess I should say it's nice to hear that it's quick.
Very
That
quick, and the recovery is, and the recovery from that anesthesia is literally they just breathe it out of their system. They wait, we turn off, we take off the mask, they wake up, they oftentimes they cry for a minute or two, and as they're crying they're literally breathing the anesthetic out, and then it's gone, and then that's it. So it's not like one of those groggy days where they're sort of recovering from anesthesia as well.
and this is something else I think a lot of parents don't realize, but tell us what happens to the tubes. Do they have to come back to you to get them removed at some point, or let, what
So the
happens to the
natural
tubes?
cord, so what happens to the tubes is the eardrum, which is a little piece of skin, senses that the tube is there. And the eardrum says, this is a little foreign object in here, and I'm going to push it out. And so the eardrum gradually pushes out the tube, and that process takes about a year, year and a half. And so 99% of the tubes stay in for about a year, year and a half, and then they fall out gradually into the ear canal. Sometimes you can see it and it falls out at home, typically just at a doctor's office, either a visit with their pediatrician or a visit with me. We'll see the tube in the ear canal, and usually we can just take it out or let it fall out on its own. Sometimes the tubes stay in a little longer. And if they're not bothering the child, we usually just let them be. And sometimes they fall out, and we actually need to go back and do another set of tubes if the child starts getting infections again, probably about 10%.
Any other common questions about ear tubes that I'm missing?
No, I think that's good. I think a lot of parents were told, or when they were kids, if they had tubes, they were told that they can't swim with ear tubes. Children can swim with ear tubes. Some of the kids, the water bothers their ears, and there are a lot of options that we have to sort of cover their ears. Either with a little head, they make these little waterproof headbands or little earplugs. Most of the kids, they don't need anything in their ears for swimming, and I certainly don't want tubes to be a reason for a child not to learn to swim. They can still swim with tubes. I think that's important
That's
to
a
know.
great that's a
Yeah.
great piece of knowledge to learn.
Yeah.
And then lastly, just I know we talked about the ears, we've talked about the throat, and since you're an ear, nose, and throat doctor, a quick question about noses. Something frequently that comes up in pediatrics are concerns about bloody noses and when to be concerned about bloody noses and when should they see an ear, nose, and throat doctor. Do you have any advice for parents about bloody noses and when they should see you?
So bloody noses are very common in kids. Some kids get a little scared when they see the blood. Typically, it's in the middle of the night, so they wake up and everything's covered with blood. So reasons that I need to see them would be if it's happening frequently. So if they're getting, a few bloody noses every week for several weeks, and they just seem to, kind of come one after the other, you'll get the calls from the schools, and get sent home, or, they're getting sent to the nurse's office, or if they're happening in the middle of the night. So that would be one reason if they're happening frequently. And then if, severity. So if your child is having bloody noses and they're lasting, 15, 20, 30, 50 minutes and you can't get them to stop, that's definitely a reason for me to see them. And, if some, typically blood comes out the front of the nose, if it's also coming out significantly in the back of the nose where they're spitting out a lot of blood, I need to take a look.
A lot of parents wonder what it's like to get their nose cauterized. Can you explain
Uh-huh.
what
Yeah,
that's
sure.
like and the recovery?
So I can usually cauterize kids, between ages 4 and up. I can, if if it's a kid who can tolerate a little bit of, holding still, I can usually do it in the office. And usually, I'll take a look first. Sometimes I take a look with a little telescope a little further back. And then I put a cotton ball that's soaked with a little numbing drops, like some Novocaine drops on the cotton ball, and I leave it in their nose for a minute or two. And then I take a little stick. It looks like a match. It's not a match. And it has a little silver nitrate on it, and which is a chemical that actually can kind of stop the blood vessels. And so I'll usually touch the inside of their nose with a little silver nitrate. Takes about 20 seconds to do. Even when I numb up the nose, though, it stings a little bit. I sort of describe it as like it feels like getting like hot pepper in your nose for a second, and then it's done. And some kids I need to see them again, 6 weeks later, and we'll either redo it or we'll do the other side. I only like to do one side at a visit because the septum is very delicate. Um, and so that's usually, we usually do it in the office. If it's a child with more significant nosebleeds, or if we need to do something further back, I'll probably take them, schedule them for something to do in the operating room while under anesthesia.
It's wonderful. It's wonderful what you can do to help kids.
Thanks.
Do you like what you do? Out of
I do. I do. It's a lot of fun. I mean, kids are a lot of fun. And it's challenging. Obviously, some things are more challenging than others. Sick kids are really challenging. Really sick kids are challenging. Um,
Are there a lot of pediatric ENTs?
it's a very, very, very small field. So ENT is a very small field in and of itself, and then pediatric ENT is tiny. So most of us know each other throughout the country. At least we've all heard of each other. So that's how
Wow.
small it is. Yeah. Yeah.
Wow.
Under 1,000, I think, for sure.
That is a small number.
Yeah. Yeah.
Considering how many children have ear infections and
Right.
need
Yeah.
their tonsils removed. Well,
Yeah.
thank you so much. Thank you for your time. It really was a pleasure, a treat, and I hope to talk to you soon.
Yeah, it was great. It was a lot of fun to talk to you. Thanks.
Thank you.